Good afternoon and welcome to today's bill hearings for the House Health and Government Operations Committee. This is a virtual committee, and as usual, we ask for your patience and indulgence if we encounter any technological streaming issues. The bill hearing is being streamed on Maryland General Assembly's YouTube channel. To the committee members, please remember that even though we're meeting on Zoom, adhere to our usual rules of one question and one answer from the panel, not one question and an answer from each individual panelist. We are open to brief follow-up question if it's really pertinent. We're also now, and we ask that you keep your questions shorter than the expected answer. The bill sponsor or designee is allotted 5 minutes to present the bill. Up to 5 witnesses will each be allowed to speak for 2 minutes in support. Please stay in the hearing, to those who are testifying, please stay in the hearing until the delegates have had an opportunity to ask questions, and only the delegates can ask questions. Next, we will invite up to 5 witnesses who will each be allowed to speak in 2 minutes or for 2 minutes in opposition. And then we ask you to stay in the hearing so that the delegates will be able to ask questions. Please conclude your remarks when you see the timer finish. We have 5 bills today that we'll be covering, and they go in this order: House Bill 166, House Bill 173, 188, 229, and 247. We will start with House Bill 166, sponsored by Delegate Sample Hughes, Alzheimer's Disease and Dementia, Council and Coordination of Services, Dementia Services Act of 2022. Madam Speaker Pro Tem.
Thank you, Madam Chair, and thank you to all the members of our Health and Government Operations Committee. I am Delegate Teresa Hessler, and I am here today to ask for your support for House Bill 166, the Dementia Services Act of 2022. This bill would facilitate the coordination of the state's broad array of dementia services by creating a director within the Department of Health who can ensure we are executing all of the work that this committee and the Alzheimer's Association has done in the past years to improve the lives of those suffering from dementia. And as fate would have it, probably 30 minutes ago, the director of Delmarva Community Services, which is very active in specifically Eastern Shore, but stopped by to share with me, which I did not know, that they're hosting a class for caregivers in this space starting on Tuesday for 8 weeks. A manual will be given to the caregiver. They have it via Zoom. It's called Savvy Caregivers. And so I was just pleased to hear that and just know that work is continuously being done locally. And this is a state effort, as a matter of fact, but having it within that jurisdiction. So things are happening, and it was just very beneficial to hear that on today, because many of you already know that 110,000 or more people in the state of Maryland are affected by Alzheimer's or dementia. And we have about more than 300,000 caregivers that need support, just as I mentioned, with regards to the upcoming opportunity for session for caregivers. And so to that end, our state is seeing about $1.2 billion in Medicaid expenses. And for me, this certainly has been a personal fight over the years. And so pretty much every session I've tried to increase or figure out what we can do by way of legislation to improve how our state responds to this particular disease and help to alleviate some of the burden for families. So last year, we were able to pass House Bill 119, again, to improve the outreach to families and others who may not even have a knowledge of the disease. So the potential of our efforts cannot be realized without strong coordination. And our state agencies need that support. The Alzheimer's Council needs it, Department of Aging. It's also important for the grants that are coming to our state through the federal government, and also there's been some private opportunities for grants. But again, it needs to have a coordinated effort to provide dementia services. And this particular position that is asking in this bill is the Director of Dementia Services. With that being said, we have witnesses here today that will elaborate on how this particular legislation can be beneficial to move the needle and help so many Marylanders to navigate the system as far as getting the information and making sure it is all streamlined. So today I ask for your support, and I ask that you continue to see that this is a need. And in fact, our state should be in a position to be able to streamline and coordinate those services. You will hear from the state of Virginia today to just indicate what they have done and many years ago put in a position such as this and have found it to be beneficial. And then lastly, the testimony that you have before you, the written testimony, has all been positive and beneficial. And there's one with an amendment to it, but that was just asking for their entity to be a part of the association and be on the panel to have the continued work. So to that end, thank you for your time, and I continue to look for a favorable report on House Bill 166.
Thank you, Delegate. I'm going to call the favorable panel first, and then we'll have questions. Let's start with David McShay.
Thank you very much, Chair Pendergrass and Vice Chair Penny Melnick. My name is David McShay, and I'm the Executive Director of the Alzheimer's Association Greater Maryland Chapter. You have my written statement, which I will summarize during my testimony. I want to thank you for the opportunity to testify today in support of HB 166. Legislation which at its core creates and provides funding for a Director of Dementia Services Coordination at the Maryland Department of Health. I'm grateful that this committee passed legislation last session to help us build awareness about dementia, and also for the Vice Chair's new law, which will help communicate disparities associated with dementia. And as we move forward in the 2022 session, the legislation before you today is essential. The Virginia I. Jones Alzheimer's Disease Council is wrapping up its work, and I hope we'll soon have the opportunity to present its expansive plan to you. And this legislation, if enacted, will help implement that state plan and build the infrastructure for Alzheimer's support across our state, which we do not have now. And the infrastructure to reach and aid Marylanders with dementia exists in certain Maryland counties. For example, in Prince George's County, the local government has been awarded a federal dementia capable grant. And in other areas like Montgomery and Baltimore County, they have staff who engage community members with dementia and their loved ones. And across Maryland's 24 local jurisdictions, however, these counties are the exception and not the rule when it comes to aiding the over 110,000 Marylanders living with dementia and their caregivers. Our state spent over $1.2 billion in Medicaid dollars on this chronic disease in 2020, and yet there's not one person in our state government solely focused on dementia. We must build the infrastructure to address Alzheimer's and other dementia in our state. And our chapter of the Alzheimer's Association is pleased to do whatever we can to aid Marylanders, particularly during the pandemic. I want to thank you so much for the ability to present to you today, and I urge a favorable report on this legislation.
Thank you, Mr. McShay. George Worthington.
Thank you, Madam Chair, for the opportunity to testify in favor of House Bill 166. I'm George Worthington, the Dementia Services Coordinator at the Department for Aging and Rehabilitative Services in Virginia. In our state's first dementia state plan, released in 2011, the first recommendation was to create a position and obtain specific funding to hire a full-time Dementia Services Coordinator, or DSC, to coordinate the services provided to persons with dementia, working in conjunction with the Virginia Alzheimer's Disease and Related Disorders Commission. The plan envisioned the role of the DSC to include disseminating information on services to individuals living with dementia and caregivers, establishing a strategy to link and coordinate the services of state agencies, service providers, advocacy groups, and the Aging Network, coordinating and supporting the Alzheimer's Commission, promoting services for all stages and types of dementia, and ensuring that the Aging Network is dementia capable. Virginia's General Assembly included $100,000 in funding for this position starting July 1, 2013. The initial and ongoing investment of state funding for the DSC has translated into millions of dollars in federal grants and better targeted state investments in coordinated and evidence-based programs. The DSC has been instrumental in driving 2 4-yearly updates to the Dementia State Plan to reflect emerging priorities. The DSC has secured and administered federal grant funds totaling over $1.25 million from the Administration for Community Living. Partnerships with the private sector established under these projects received a further $2 million in ACL grants. The DSC has been instrumental in helping secure a current BOLD Act grant from the CDC of close to $1 million. This funding has helped lay the groundwork for Virginia's dementia capability by implementing training for healthcare professionals, first responders, and direct support staff. The DSC has also represented the voices and needs of people with dementia. I urge a favorable report for HB 166.
Thank you, Mr. Worthington, for taking your time out from your job in our neighboring state to be here with us today. Mr. Quincy Sams.
So thank you very much. It's actually Mrs. but I'm pleased to testify no problem, in support of Senate Bill 27, Dementia Services Act. I am a health services researcher at the Johns Hopkins School of Medicine with nearly 2 decades of experience conducting Alzheimer's disease and related dementia research. I've served as the chair on the Virginia Jones Council since 2019. Having been raised by my grandparents on Maryland's Eastern Shore, and perhaps like many of you, having witnessed firsthand the impact of ADRD on loved ones, the need to do better, to reduce risk, and to improve care is personal. ADRD represent an urgent, high burden, and high cost public health crisis in Maryland. Our research at Johns Hopkins shows that unmet dementia-related needs among Marylanders are very common, but often go unevaluated and unmet, leading to excesses in poor outcomes and higher healthcare costs. ADRDs are actually the most expensive chronic condition in the US, surpassing heart disease and cancer. You've heard the numbers on Maryland's Medicaid spending, and the $1.2 billion is expected to increase to $1.5 billion by 2025. Effective interventions, including those developed here in Maryland, are available, yet not well coordinated or widely accessible. Further, best available research evidence suggests dementia risk could be reduced by 35% by modifying risk factors over the life course. This bill establishes a full-time director of dementia services position in Maryland Department of Health, which in my view is a critical step for building on and coordinating existing efforts in Maryland. Supporting a state-level champion for ADRD and brain health comes at a critical time as new national bipartisan infrastructure and research opportunities are available at unprecedented levels. This position will be key for successful implementation of the forthcoming state plan. I respectfully urge a favorable report to ensure effective and equitable dementia care. Thank you.
Thank you very much. And Eric Coltramiro.
Hi, Delegate Kellison, just here informational to answer questions.
Thank you, Eric. Okay, that concludes the sponsor panel then. I am open to questions from the committee members. Please use the raise hand function. Delegate Johnson.
Thank you, Madam Chair, and thank you, Delegate Sample Hughes, for bringing this bill and panel. This question is for Delegate Sample Hughes. From the Health Facilities Association of Maryland, they requested that a member from that organization be on the council. Do you see that as being beneficial to the bill?
Thank you, Delegate, for the question. Yes, when I reviewed the testimony and indicated that they want to be a part of it, personally, yes, I do feel that that is beneficial given the fact that they're on the front line with our long-term healthcare facilities and knowing what the needs are there. So officially to bring it in, then that's another step in the process. But at face value, yes, I do agree.
All right, thank you. Thank you, Madam Chair.
Thank you, Delegate. Delegate Shalega.
Thanks. Thank you, Delegate Sample Hughes, for bringing this bill. I was wondering, I'm a member of the Maryland Commission on Aging. And so we talk about these things that, we have a meeting next month. And it looks like the gentleman from Virginia, they're nested under the Department of Aging, and I guess he said rehabilitation. So was there a reason that you put it under health and not aging? Just wondering.
Sure. Thank you, Delegate. So the council that is in place now is underneath the Department of Health. And so the Alzheimer's Council that I sit on as the state rep and from the House, and then Senator Augustine from the Senate, is underneath the Department of Health umbrella, and some of those grants that are coming in are filtering through that particular agency. So in order to try to streamline it and to continue to see that as a direct feed, that was where we placed it at. But certainly when I looked at Virginia's model and figured that, you know, it was good and it worked for them. But where we are currently right now, that was the department that I felt that would be best beneficial under.
Okay, I was certain you had a good reason. And
Yes,
did
and we have a representative from Department of Aging on the council as well.
Yeah, that's what I was going to say. I hope that somehow we can get a more collaborative work environment with you guys, because clearly, you know, the local aging departments of aging are working on this as well. So great. Thanks so much.
Yes, they're a member already. Thank you.
Great. Thank you, Delegate. Delegate Hill.
Thank you, Madam Chair, and Delegate Sample Hughes. Thank you for the work you've done. I don't know, 7 or 8 years working with the commission and really helping it to get its feet under it and do really significant work. So as I look at the bill, in addition to defining a director, it also eliminates the sunset and makes the commission permanent, but it defines terms, but it doesn't seem to speak directly to how folks are appointed or how quickly they have to be appointed if there's an open seat. And the second part of the question is the fiscal note says that even though the role of the coordinator is funded initially, the language in the bill does not really serve as a mandate to make sure that there are ongoing appropriations. And I want to know if you were aware that the fiscal note says something needs to be done to make sure that that's budgeted every year.
Yes, I am aware. And let me refer you to Eric for the response to your first part of the question without me responding.
Delegate Hill, I'm not sure if I'm going to answer your question thoroughly. I would just say, as far as appointments, we work closely with the administration to fill the appointments, and when there are vacancies, to fill those vacancies. And I just wanted to make one more point, if I may, Delegate Collison, just to Delegate Shalega's question about why this is in the Department of Health as opposed to the Department of Aging. Two real quick things. One, this is the recommendation 1A of the State Alzheimer's Council. But two, more broadly, dementia, much like diabetes and other areas under the health department, is a chronic disease. And to best address this chronic disease, because of the $1.2 billion that are spent in Medicaid, also placed in the Department of Health, we feel that the Department of Health has the infrastructure, and this individual is best placed in that department to serve in a cross-cutting way across state agencies, certainly including our partners at Aging, to help coordinate the response, the quality of care, and the implementation of the forthcoming State Alzheimer's Council plan.
Okay, thank you, Eric. Seeing no other hands, I would like to follow up. Delegate Sample Hughes, are you confident that the bill as written gives the agency enough direction about how to fill this position and build the infrastructure? Or do you think, or is this something we should perhaps work on in subcommittee?
Sure. Thank you, Delegate. I believe that as it is laid out, it provides the framework of specific tasks, the analyzing, working on specific grants, and securing those partners to bring to be at the table, and that provides that framework within this bill as it stands. I do believe that additional work in the subcommittee, because I believe additional ideas to firm it up, if you will, make it even tighter, would be beneficial given the relationship that we sometimes have with the Maryland Department of Health, and it may not be as clear to them as they may need it to be.
Thank you very much, Delegate. Seeing no other questions, I would remind the committee that there is a wealth of written testimony. Please take a moment to check that out. And that concludes the hearing on House Bill 166. And we will move to House Bill 173, Delegate Bagnell. This is State Board of Social Work Examiners, temporary license to practice social work. Delegate Bagnell.
Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. For the record, I'm Delegate Heather Bagnell, District 33, Anne Arundel County, here on behalf of HB 173, State Board of Social Work Examiners, temporary license to practice social work. House Bill 173 is a reintroduction of Senate Bill 167, which passed both the House and Senate during the 2021 session, but did not make the return to the Senate chamber in time for final passage. The bill in its current form reflects the House amendments of SB 167 as it was passed, and the vote of this committee was unanimous. As this committee will recall, during the COVID-19 pandemic, testing centers were forced to close, which prevented social work students from taking their final licensing examinations. This significantly limited work opportunities for students, prevented employers from being able to employ enough workers, and created an additional burden to care for Marylanders. This bill was a reaction to the delayed testing, which delayed licensure for social workers during the COVID crisis. HB 173 will permit the State Board of Social Work Examiners to issue temporary licenses to practice for applicants who, except for passing an examination, have met all other education and experience requirements to be licensed as social workers. The discretion to exercise this rule remains entirely with the board, who may, if deemed appropriate, issue a temporary license if the examination is unavailable to an applicant for at least 7 days. Further, the license would be valid until 90 days after the examination becomes readily available. You will see in the testimony that the Board of Social Work Examiners maintains their opposition to the legislation. I have had a robust discussion with Mr. Weinstein regarding the concerns of the board and conveyed our intent that this bill provide a behind-the-glass discretionary tool should another unique emergency situation arise in future where it would be required, but we were unable to come to consensus. The authority on whether to issue a temporary license to an applicant who has not yet passed the final examination remains entirely with the state board. The bill stipulates that a temporary licensee may practice social work only under the supervision of a board-approved supervisor while the temporary license is in effect. Furthermore, the board maintains authority to restrict or regulate the temporarily licensed social workers as they deem fit. If there is an overarching lesson from this health crisis, as well as recent cyber attacks on our infrastructure, it is be prepared. We cannot assume that every crisis will occur during our 90-day session when we can take action, but rather we need tools readily available to respond. HB 173 is one such tool and is consistent with other efforts to expedite healthcare licensure during the COVID crisis, and I respectfully request a favorable report on House Bill 173.
Thank you, Delegate. I'd like to call upon Mary Beth DiMartino.
Thank you. Good afternoon. My name is Mary Beth DiMartino. I am the Executive Director of the Maryland chapter of the National Association of Social Workers, and I am a licensed certified social worker clinical. Thank you, Delegate Bagnell, for introducing this legislation that is so important to Maryland social workers. And as you said so eloquently, it did pass the House and the Senate last year. So to provide a little bit of background, during the height of the COVID pandemic in April of 2020, our chapter did receive numerous calls from concerned social work students, as well as employers who weren't able to have their constituents get licensed at the Board of Social Work Examiners. And people were very concerned. Social work students weren't able to sit for their licensure exams. Students who were about to graduate, students in Maryland who are able to begin the process of applying for licensure, they can do so in their final semester of study at a graduate program or an undergraduate program in Maryland by completing an application and completing a background check and paying the necessary fees. And then once you have verified from your institution that you've completed all the requirements for graduation, you can submit that documentation and be licensed right away upon graduation. And you don't have to wait to be licensed. But we were contacted by students who could not sit for their licensure exam because of COVID. Students were very concerned because they had job offers that were waiting for them and they couldn't accept them. And also employers were contacting us as well because they had people they couldn't hire. In my previous employment in child welfare, I also experienced many situations where we couldn't hire people because they were waiting to sit for their exams. And again, this fall, when a security breach caused the state's computers to be inoperable for a small period, licensees also saw long delays in the processing of licensing applications. At the January meeting of the Board of Social Work Examiners, there were also applicants expressing concerns.
I'm going to have to ask you to wrap up, please.
Okay, I'm almost finished. Thank you. So obviously things are slower to reduce capacity, and we're just asking that you support House Bill 173 to just make it possible for this to be at the disposal in the case of an emergency. Thank you.
Thank you very much for your testimony. Scott Tiffin, please.
Thank you, Madam. Thank you, Madam Chair and members of the committee. My name is Scott Tiffin. I'm also here on behalf of NASW Maryland. I mostly wanted to be here to answer any questions, but I did want to highlight, I think, 2 points. One is that, as Delegate Bagnall said, the board is opposed because of public safety concerns. But the bill does require supervision, very similar to the way that student social workers are supervised. So essentially, you can be supervised, practice while you're in school, but then the day after you graduate, you would no longer be able to practice, even under supervision, under current law. And then, as Mary Beth said, this is really just a tool in the toolbox that we think the board needs for emergencies. And Governor Hogan kind of recognized the importance of this tool in his most recent executive order when he called on all the boards who have the power to do temporary licenses to consider doing so. Unfortunately, the Board of Social Workers was not able to do that because they're not currently authorized to issue temporary licenses. So we just ask for a favorable report to prevent future issues along these lines. Thanks.
Thank you. Teresa Hessler, please.
Good afternoon, Madam Chair, Vice Chair, and members of the committee. For the record, my name is Teresa Hessler, and I am here on behalf of the Maryland Association of Resources for Families and Youth, otherwise known as MARFI. MARFI is an association of private child caring organizations providing foster care, group homes, and other services through more than 200 programs across Maryland. The members of MARFI represent providers who serve Maryland's most vulnerable children who are in and out of home placements due to abuse, neglect, or severe mental health and medical needs. We support the passage of House Bill 173, which would help to alleviate the burden of the current worker shortages that many of our providers are facing due to unforeseen challenges caused by the COVID-19 pandemic. The delay in a graduate's ability to sit for their exam to obtain their licensure considerably impedes an employer's capacity to offer employment, hindering clinical services that our youth, families, and communities require. It has taken many agencies over 10 months to fill social worker positions in some group homes. Pandemic-related stress has affected everyone, including individuals in helping professions. Designated as essential workers, social workers have continued reporting to work. As staffers and worker challenges continue, the state of our current mental health needs as it pertains to caring for our most vulnerable populations far exceeds anything MARFI members have ever witnessed. We strongly advocate that the modifications to current practices proposed in this legislation be considered, which would help to address the current worker shortage, therefore supporting mental well-being of our providers, as well as further ensuring the safety of our youth, families, and communities. It is for these reasons we politely ask for a favorable report on House Bill 173. Thank you.
Thank you. Dawn Schaeffer, please.
Sorry about that.
There we go.
See. So good afternoon. Thank you to all the members of the Health and Government Operations Committee. My name is Dawn Schaeffer. I'm the Associate Dean for Student Affairs at the University of Maryland School of Social Work. I'm also a licensed clinical social worker and a board-approved supervisor. I'm testifying today on behalf of the University of Maryland School of Social Work.
I'm just checking on you. Okay, you're in the Zoom.
In favor of House Bill 173. I first became involved in the discussion of temporary licensure when I was approached by graduating MSW students in March of 2020. At that time, many students who had already scheduled their LMSW exam were contacted by testing centers closing due to COVID-19. Exams were delayed from several weeks to months, resulting in rescinded job offers, loss of income, and compounding stressors during an already difficult time. Our students wanted to aid in the public health crisis response during the pandemic, but without a viable path to licensure, were unable to do so. We at the school know that our students are well qualified to begin serving immediately upon graduation. We're a highly ranked program accredited by the Council Work on Social Work Education. We prepare our students through rigorous coursework and 2 years of field practicum. A large percentage of our students pass the LMSW on their first attempt, many before they even graduate. If temporary licensure were to be awarded, those in possession would still practice under a fully licensed social worker. Thus, temporary licensure does not pose a risk to the public. Social workers understand the implications of healthcare inequity, which lead to worse outcomes for underserved communities, the same communities who are more impacted by public health crises. In the example of COVID-19, the public health crisis created greater demand for services, but fewer providers to serve given the reduction in test availability. While this bill is not specific to COVID-19, the pandemic was an example of a time in which Maryland was not able to quickly respond to a state of emergency. This impact was also felt by the recent graduates who were unable to secure employment, thus impacting their ability to pay their bills and begin their student loan repayment. Many graduates remained in non-social work positions despite being qualified in all other ways. Having access to expedient licensing processes, particularly during times of crisis, is vital for social workers, clients, and for employers. Thank you for your time.
Thank you. That concludes our favorable panel. I'll now open it up for questions from the committee. Are there questions? Delegate Saab.
Thank you, Madam Chairman. I guess my question is, I was just looking at the opposition from the
No. Delegate Saab, you're on mute. There we go. You're back.
Yeah, thank you very much. I appreciate it. Thank you, Madam Chairman, and thank you for this bill. I think time has changed a little bit. So one of my concerns is actually what the State Board of Social Work Examiner concern is that 20% of applicants actually fail the test. And I guess the question is for the delegate or for the panel is, does that concern that 20% of those people will be practicing social, the professional without have passing the test?
Who feels best qualified to respond to that question?
I'm happy to try unless someone else wants to jump in.
Okay, Scott?
Cool.
Yeah.
So I think, that statistic is, accurate, but there's obviously a lot of different reasons why someone may fail a test. They may be perfectly qualified to be a social worker, but just not be a great exam taker. But with that in mind, that's why we felt it was really important to include a requirement that they be supervised by a licensed social worker who will oversee any work that they are providing, just to make sure that, all the T's are crossed and the I's are dotted. And similar, like I said, this is similar to when they're a student, which is pre-exam as well. They're allowed to practice social work under the supervision of a board-approved supervisor. So we think that kind of helps alleviate any public safety concerns.
Does that help, Delegate?
A little bit, yeah. Thank you. I appreciate it. Thank you, Madam Chairman.
Thank you. Delegate Hill.
Thank you. So Scott, what's the difference between the temporary licensure under this bill and just allowing them in a state of emergency to continue working under a supervisor as a student? Why can't they just continue to be students? And why do you have that they can get it if they can't get a test for 7 days? Seems like an awfully short time to have a test not available to then be eligible for a temporary license.
So the way the student exemption currently works in statute is it evaporates, so to speak, once you graduate. So we would have to change that somehow in order to make the student exemption continue on once you walk across your graduation stage. The reason for the 7-day availability was something this committee added into the bill. Originally, it was just if it was unavailable. I think this committee had concerns if it was unavailable for 1 day, would that warrant, the necessity of these temporary licenses? We're open to changing that timeline if the committee feels differently this year. But I think our main point is if it's unavailable for some extended period of time, it should the board should at least have the power to issue these temporary licenses.
Thank you.
Okay. Delegate Krebs.
Thank you. I think I remember having an extensive conversation about this bill last year, and I wasn't really thrilled with it last year. So my question has to do with this time period as well. You keep talking about a state of emergency, but nothing in the bill talks about a state of emergency. So I have a number of other issues I won't bring up now, but why not just say in a state of emergency if it's not available? And how is this different from what the governor allowed with loosening up regulations for other health occupations during the real state of emergency?
Mm-hmm. I apologize if we made it seem like this is supposed to be just for state of emergencies. There might be circumstances where the test is unavailable, but it's not actually an emergency to the state of Maryland. If there was ever a cyber attack against the company that actually administers the test, that might make the test unavailable for an extended period of time, but there would be no reason for the state of Maryland to issue a state of emergency. And so in that circumstance, maybe it would make sense for the board to be able to issue temporary licenses. It's a little bit different than what happened under some of the governor's orders. Under most of the governor's orders, a lot of the things that were helpful this time around were things to allow people from out of state to come into the state of Maryland, but there was very little to help pre-license folks enter the workforce if necessary. There were things to allow retired folks to come back in, but there were very little things in the executive orders to let pre-license folks in if there wasn't somewhere in statute already.
No, I understand that. The previous question really, I think, was a better idea if we really have this situation in the future. But what you just mentioned about not having the test available under any circumstances, that's true with every board and commission. And that's opening up a Pandora's box in my mind. So we'll have to talk more about that. I like the previous, legislators' suggestion about extending a student if this occurred again. But thank you.
Thank you.
Thank you. Delegate Riley. Delegate Riley? I know you were there.
Yep, unmute. Yes, thank you, Madam Chair, and thank you, Delegate Bagnall, for the bill. We certainly do need more social workers out there on the job. So I understand the concept of the bill, and we're saying that this could probably help in that situation to go ahead and get these people on the front lines, helping our patients and so on and so forth. But as Delegate Saab was talking about, we do have a letter also from the Public Defender's Office, and they mentioned, the failure as well in the exam, but they also talked about the liability, the responsibility of the supervisor in this particular bill that's supposed to oversee this person with the temporary license. And that if they have to continue to oversee because of the liability situation, that's not really going to help, more social workers out there serving the patients because they're going to have to be overseen by the supervisor. So I'm not sure that, the bill is going to actually help what we're trying to fix and then address that liability factor. So I don't know if one of you, have seen the opposition on that point, but if you could explain that, that'd be great.
Go ahead for me, Beth.
I was going to say, I'd be willing to try to speak on that. I am a board approved supervisor, and prior to, this is my third week at the NASW. So prior to that, I've worked for almost 30 years in the field and have worked as a board approved supervisor for many years. And I would just like to say that as a supervisor, you have a very close relationship with your supervisee. You have a written contract, and that contract between you and your supervisee can be discussed at any time. And so if you as a supervisor don't feel like that person is someone that you feel comfortable representing or being in that contractual relationship any longer, you can terminate that relationship at any time and say, I no longer feel comfortable with this person. You can always go to the board and say, I no longer feel like this person is a good person to be out or whatever. And you can always terminate that contractual supervisor relationship. So that's always at your discretion. So I think, that is always a relationship that each person enters into willingly and within that confines of supervision and can discuss that. So, you take that liability on, with a discussion between the supervisor and supervisee, and you always have the ability to freely terminate that relationship.
Okay, thank you for that answer. Madam Chair, could I have a follow-up on that?
Yes.
Same point. Thank you. With that said, under this particular bill, if that situation would happen and the supervisor was not happy and really felt that this, temporary license is not working for this person, and so does the bill allow that as well? And will they automatically, have to give him or her another supervisor during that temporary license? Or is there a place in the bill to where we say, okay, this supervisor says this isn't working, this probably is not the career this person needs to go through, so then the temporary license is taken away?
So that's a really great, all of us as social workers and board approved supervisors, we really adhere to our code of ethics, and as a profession, as social workers, we adhere to that. And so we would obviously see that as something that we would need to consider depending on each situation. But if somebody was completing, and doing something egregious, then certainly that would be something we would need to report to the board or, discuss or with that employer, depending on what the situation is. But clearly, if someone was, doing something of gross negligence, certainly that would be something you'd want to discuss with the board, report to the board. There's a channel for doing that.
Okay,
so
thank you very much. Thank you.
Madam Chair, may I follow up to?
I'm sorry, we were only one panel, one answer from the panel. We can follow up offline, and there'll be a work session on the bill, which you would be invited to. Delegate Kelly.
Thank you, Madam Chairman. I'm not sure who would best answer this question. My guess is Scott, but if you want to defer to someone, let me know. But I remember from the conversations around this bill last year, and again, the subcommittee worked on this for a number of weeks, and we did pass it out last year, unanimously, I believe. But one of the things that we have done over many years is look at this idea of temporary or provisional licensure with a number of different boards. So I'm looking at one of the letters in the file, and it says that already in Maryland, this process that you're proposing is used currently by the Board of Dental Examiners, the Board of Morticians and Funeral Directors, the Board of Nursing, the Board of Nursing Home Administrators, the Board of Occupational Therapy Practice, the Board of Physicians, the Board of Podiatric Medical Examiners. Quite a number of our current boards use this process. So one of the bigger picture conversations we're having is how to sort of streamline the work of the boards and make things easier and more understandable. Is there a benefit to passing this bill so that, as you mentioned, if the Department of Health is looking for ways that they can encourage the boards to help out in an emergency, and they issue a directive like, hey, if you've got temporary licensure, this is the time to use it. How does this play into sort of the context we're in now, and the question of how can we get all the boards sort of working on the same page, doing the same thing to the best of our ability, so that we don't have 45 different sets of rules for 24 different boards?
No, I think that's all completely accurate. Like you said, I don't know if I could say most, but a large number of the boards do have temporary licensure powers. And actually several of those aren't really discretionary. You are entitled to a temporary license pre-exam if you're being supervised, for example, if you're an LCPC and you meet every other requirement under law. So this is even a little bit tighter than what some of these other boards have to deal with. But when there's a situation where the exam might be down for several months, the state may run into a situation where we just don't have enough social workers. And we all saw a huge increase in need during the pandemic, and there just weren't folks to always meet those needs. So I hope that helps answer the question.
You're on mute.
Sorry, brief follow-up, Madam Chair, if I may.
Yes.
So just sort of to clarify then, it's your position that the Board of Social Work didn't have the appropriate tools that some other clinicians, or I guess the profession of social work, didn't have the tools that other clinicians providing care did have at their disposal during this crisis, and this bill would help with that.
That's correct. Yeah, we did ask, I believe at the January board meeting during the very beginning of the pandemic, if the board was able, under their own authority, to issue temporary licenses, because we were seeing problems, and the board said no, they didn't have the statutory power to do that.
Thank you very much.
Okay, I have a what I think is a pretty simple question. If you are a student who is working in a center under supervision, are you being paid?
I'm sure Dawn probably is the best person to talk about students.
Dawn?
Yeah. By and large, for the most part, no. When we have a small number of agencies that have stipends that are attached, or folks that are doing fellowships that are through sort of other avenues, but no, students are not paid employees.
Okay, so if they graduate and then are allowed a temporary license under a bill like this, we would assume they would be paid as an employee of the workplace. Would you make the same assumption?
Yes, ma'am.
Okay, thank you very much. We do have a panel of unfavorables, and I'm going to ask Stanley Weinstein. Stan, are you out there? Don't forget to unmute. Richard, is he here?
Yes, he is here.
Oh, there he is.
Madam Chair, Madam Chair and committee members, thank you very much for the opportunity to testify. I'm the Executive Director of the Board of Social Work Examiners, and while sympathetic and understanding the concerns brought up by my colleagues at NASW and the school and Murphy, the board strongly opposes House Bill 173. And the issue is that NASW and the school is concerned about the student and concerned about the profession and social workers. The board's mission is to protect the public and is very concerned about what the risk involved is. We're not talking about a few people, like the occupational therapy has 7 people on a temporary license. We're talking about if we take all the LBSWs and LMSW applicants, we're talking about over 300 temporary licenses. And I'm not sure how you would feel if you went because of a mental illness or have a relative who's been abused or been a victim of domestic violence, whether you would want your social worker to not meet a minimum standard for safety, knowledge, and ethics. The exam is very broad in its focus on safety of practice and is targeted towards people who've just begun to practice. They studied over 5,000 people at beginning jobs and want to be sure that people have not just the knowledge that they'll get from school, but they'll have the ethical judgment and safety to be able to treat these very risky populations well. So the board feels consistent with their mission that this is not something they want to do. Yes, the past year was a crisis with the pandemic, and it was the first time the exam was delayed by a month in 45 years. The cyber attack to the Department of Health certainly didn't help this year. We have our chair who's here also testifying, but let me just end saying that the board's feeling is that this is not an option that they want. And to our knowledge, no behavioral health profession offers a temporary license.
Okay, thank you, Stan. Karen Richards?
Hi, thank you, Madam Chair. I'm Karen Richards. I'm also a licensed clinical social worker in the state of Maryland for over 20 years. I've also served on the board of social work examiners for the last 6 years, and I'm currently the board chair. I certainly identify and respect the position of the School of Social Work, NASW. I felt for the students this year, graduating into the COVID pandemic, but I continue to stand with our board's position, which is in opposition of this bill. I think the important thing to kind of recognize a little bit is that last year in the COVID state of emergency were very unusual times. And I also want to point out that our profession is just a little bit different than some of the other healthcare professions. I'm just going to throw out an example. If I come into the emergency room with my husband under COVID because he can't breathe, the first person I want to see is not a social worker. It's a medical profession. It's a nurse. It's a doctor. Later on, once he's stabilized, and we're preparing for discharge, yes, then I would want to see a social worker to help me. And at that time, I want to make sure that I have a very competent social worker. And if you've been to a hospital, I want to tell you, how many social workers do you recognize off the bat? When you first come into the emergency room, you right away see all the nurses, you see all the doctors, you know who all them are. In the back trenches are the social workers. We're a smaller profession. And yes, under this bill, you would be supervised, but understand that in a hospital, you might have a handful of social workers. So you might have one supervisor supervising 5 social workers. You have to send your social workers out there to do the job, to meet with patients. Then you come back and meet with them for supervision. I want to know that that person who comes into me, I'm not meeting with their supervisor. I want to know that they're competent.
Right.
And that is really
Richards, I
why
need you to
we're
wrap up.
opposed to the bill.
Okay.
Because it's about protecting the public.
Thank you. Thank you very much. Terry Collins Green.
Good afternoon, delegates, and thank you for allowing me to provide oral testimony on House Bill 173. I am the director of the Social Work Division for the Maryland Office of the Public Defender. I've been a licensed social worker in Maryland since 2007 and a board certified supervisor since 2013. Additionally, I have been an adjunct professor with Morgan University School of Social Work since 2016, and I am a field instructor for social work interns. I want to reiterate that the sole purpose of a licensing exam is to identify persons who possess the minimum knowledge and experience necessary to perform tasks on the job safely. The responsibility to ensure that the job tasks are performed safely under this bill would fall to the responsibility of the board certified supervisor. That person would be working under my license. I am concerned that we've identified that 20% of applicants fail the exam. In addition, it's my vast experience that MSW students and graduates need a level of confidence that they get in practicing social work once they've passed that exam. Secondly, there has been a shortage of social workers in the United States since 2016, and that's based on a report from the Health Resources and Services Administration, National Center for Health Workforce Analysis. This will not fix the shortage of social workers. And last, the Association of Social Work Boards Model Social Work Practice Act that was established in 1997 has continuously and unwaveringly maintained a longstanding standard that to practice social work competently, you have to have graduated from an accredited school of social work and pass the licensure examination. Thank you.
Thank you. That's the last member of this panel. I'll open it now for questions from the committee. Delegate Kerr.
Thank you, Madam Chair. When does, for the 20% that don't pass the test, when does the retest take place, and how many of those 20% pass it on the second try?
I'm not sure if it's 60 or 90 days, although that can be shortened upon request. And the passing rate for those who fail the test is rather low. I don't know the exact percentage, but generally people who do not pass the exam generally don't going forward. Now a percentage do, but there is a higher percentage that don't.
Okay, thank you, and thank you, Madam Chair.
Okay. Delegate Hill.
Thank you. Ms. Richards, this issue, again, every health professional is different, and in some health professionals, students are really pretty independent, and it's a very small step from being a student than being certified, after graduation to work independently. So what is it about social work that, other than if they're allowed to have a temporary license, they can get paid for the work? What is it about social work that you're seeing where you talk about patient safety and the public safety, but aren't the students already doing the work that these temporary licensees would
I think as being, I've been a field instructor and a board approved supervisor, I think you supervise students a lot, much closer. Also, I do think, again, this more broadly, what we're talking about is really a shortage of social workers in several professions and fields. And, having served on the board for 6 years and having, sitting in on discipline hearings and some of the things, many of the discipline cases that come across the board's purview are and again, even within the COVID emergency, you think, there's been a increase in telehealth. That requires a lot more independence. It's just a much more, independent type of practice when you're in an emergency room and, the patient is surrounded by medical professionals, but yet when that social worker goes into the hospital room, most often they're going to go in on their own. It's one social worker meeting with the family, meeting with a patient. The nature of the work we do requires that kind of confidentiality. So you do need to have a minimum level of competence to be able to send that social worker out. And as previously stated by the social work from the public defender's office, it's on that social worker supervisor's license is who's going to be incumbent upon the discipline. If a discipline case comes through and you're supervising an unlicensed social worker, then it's going to be on your license. So that is the concern. But again, the board's opposition to the bill is primarily focused on the fact that the mission of our board is to protect the public. We understand the licensee's frustration, and we understand certainly the shortages of social worker, but we oppose this bill because it is in opposition to what our board's mission is, which is protecting the public.
Madam Chair?
Yes, go ahead.
So I guess what I'm not understanding, this bill is enabling. It doesn't require that you do anything. It's a tool.
I'm sorry, I'm having a hard time hearing you.
I'm sorry, the bill is enabling. It does not require that, it doesn't tell you how you have to set up. So if there's that much difference between a student the day before they graduate and the day after, you could, as a board, set up very stringent requirements of what a temporary license allows folks to do and not do, and what that supervision has to look like. So I'm really not clear why, since it doesn't require you to set up a temporary license, you wouldn't want the flexibility to do it if you had a reason to do so. In the future.
I think the concern is, I think also that it just, the bill, the way it's written, you know, it allows for some confusion between, you know, kind of clients and employers, you know, on the temporary license. So there's questions again about whether or not we set up the bill, and if there'd be, you know, even within my agency, you know, some of my social workers who are board approved, you know, depending on their workloads, they can't take on supervising an LMSW. I question if I ask them to take on supervising a social worker who hasn't even passed the minimum exam, if they'd be willing to take that on. You know, I work within the Department of Juvenile Services. You know, we have shortages, and our workloads are pretty heavy. So if I ask a board approved supervisor to take on an LMSW, they think about it pretty hard. If I ask them to take on a graduate social worker who hasn't even passed the exam, they're probably not going to, you know, because they're not going to be as willing to accept that risk.
Thank you.
Thank you. Delegate Bandari.
Yeah, thank you. Thank you, Madam Chair. We all agreed that there is a staggering healthcare workforce crisis, and this bill is trying to help that mitigate. And the research shows that state support is needed. And this bill is talking about additional flexibility to supplement existing staffing with appropriate supervision. This question is to Mr. Stanley. When the research says that we have the shortage, what do you think that we could do as a committee to mitigate that situation if this bill doesn't work?
For the issue of the shortage?
Yes.
I don't know. I think that's a different question. You know, there are limits to it. The governor's executive order on first glance looks like he's opening up the doors for a lot of people to practice the health professionals. He targeted it just to hospitals. The governor never asked any of the boards to allow people to change to a temporary license. And I think that was done out of caution and also concern for the public. Physicians board, there's a shortage of physicians, has been a shortage of physicians. We don't allow temporary license to physicians, to my knowledge. I think the issue of workforce development and how to bring in more people, I think this is a good question that deserves to be studied. I think part of it is that social workers have expanded their roles. They're doing more things today than ever before. Years ago, you wouldn't have thought that the profession providing the bulk of mental health services in the state of Maryland would be social workers, but that's the statistic, and it's true not only here, but it's true across the country. Social workers are providing a variety of roles in geriatric care that hadn't been done before, in traumatized children. So it's an expanding role, and we're dealing with a lot. I'm a social worker, and I believe in the competency and skills that they have, but I think not everybody meets that minimum standard, and that's the concern.
Thank you for sharing your wisdom.
Thank you, Delegate. Delegate Saab.
Thank you, Madam Chairman. I actually have a follow-up on Delegate Hill's question. So this is an enabling legislation, so allow the board to decide whether they give, because it says may, and obviously if the board is opposed, so they have the discretion to deny the licenses. And so if you can just expand on that, and also how much would this addition add to the workload of the board when they have to decide whether to deny or allow temporary licenses? Thank you.
Well, thank you for that question. It's the workload, it would increase it dramatically. No, I forgot the first part of your question. If you could go back and remind me, please.
Just since the board is opposed and the bill is enabling, it says may, not
May.
shall.
Oh,
So would the board just deny the applications?
well, I think it's related to workload. The fact that we may means that the 1,500 applicants could apply. And that means each would have to be dealt with individually. We would have to process the request. The board would have to take its time to address each one, or even through a committee. And then in truth, there's more work afterwards, because if the temporary license, what if someone doesn't then apply for a permanent license? And then we have to go. What is the risk to employers of having an unlicensed, when the temporary license is over? What's the risk to employers in terms of liability regarding the practice of that individual? All this becomes then an increase in complaints to the board. I think it would be a significant change in terms of the workload of the board. The board has 15 staff people. We license 17, we have 17,000 licensed social workers in the state of Maryland. So I think something like this could increase the workload.
Thank you. Thank you, Madam Chairman. I appreciate it.
Okay. All right, seeing no other hands, I am going to ask a question. Ms. Richards, are you aware that nurses are allowed to practice pre-exam before? So, and because you held nurses up as the standard, and I would expect a high quality
Yes,
and highly
absolutely.
professional person.
Absolutely.
So that's I'm glad you're aware of that. And I guess my question is, you've said that, so the bill really deals with two different people, one who haven't had the opportunity to take the exam, and the second is someone who may have failed the exam the first time they took it. We are all talking about the shortage of social workers. Everybody agrees there's a shortage of social workers. The minimum standard in my mind is the graduation program. The test is one thing. It is, I'm an old educator, and that a summative test tells you very little about the skills, tells you something about the knowledge, but very little about the skills of the person to deliver the service. It's important. I'm not saying it's not important, but in my mind, the exam is not the minimum standard. Whereas graduating from an accredited college with the credits needed to be the licensed social worker is. So given that, what would it take to, and also to say, and I get worried when I hear Mr. Weinstein say those 20% never pass. And I think, Stan, you spoke to workforce development.
Yes.
So what would it take for the board to look at this as a professional development opportunity for both these people who haven't taken the exam and the people who have failed the exam in order to build that cohort of social workers? And I broke my own rule and spoke too long, but Ms. Richards, please.
I think, pardon me, Kerr.
Go ahead, Doc. No, go ahead, Dr. Weinstein.
I think the Association of Social Work Boards is looking into those questions. The question of the fail rate and what can be done. And they've, as a matter of fact, expanded the arm of the organization to do more research. And so I think some of these questions are being addressed and examined. I don't know the time that it would take for there to be a change in policy or recommendations, but people are looking at this issue.
All right, thank you. Delegate Kelly.
Sorry, I just wanted one more clarification. And it again goes to something Mr. Weinstein said, because in addition to, I think, not having an understanding of all the different boards that do already have a temporary licensure, you mentioned that the governor has not yet asked for the boards to establish such a process. And it is my understanding that there will be legislation this session asking exactly that, that all the health occupations boards shall establish a process for temporary licensure or practice. And I don't always agree with the governor on everything he does, but I will say that I think that across this committee, we have seen a need for more standardized processes to allow the flexibility that we have needed during this pandemic. So I really hope you take that seriously, and Delegate Cullison's questions as well, because I think they're very important. So if you'd like to respond to that, I would appreciate it.
I think there's been some discussion about that bill. Most of the boards I've talked to are not in favor of that because there's really more issues to the training and to the approval of the different professions, and I can't comment on others. I think there's always going to be some tension around this issue, particularly when there's a workforce issue or shortage. And so I look forward to studies that examine this and creative ways of trying to improve it. I'm not saying it's perfect at all.
Okay. All right. Thank you all very much for your time and your testimony. That concludes the hearing on House Bill 173. And we'll move to House Bill 188, which is sponsored by myself, Delegate Cullison, acupuncture licensure requirements. And here is a bill where the applicants want to take the national exam. What this bill does is changes the requirements for licensure of acupuncturists in the state. And I understand from the board that there are going to be some clarifying amendments that we will work on in committee. But and I'm going to let them, the board, now explain to you why they think this is necessary, why this change is necessary, and be able to answer your questions. So with that, I'm going to turn my time over to Sherry Black.
Thank you very much. My name is Sherry Black. I'm an licensed acupuncturist and vice chair of the Maryland Board of Acupuncture. I appreciate the opportunity to speak with you today. So this bill would require that after June 1, 2026, applicants for licensure in the state of Maryland must both graduate from an accredited school of acupuncture and take a national exam given by the National Certification Commission for Acupuncture and Oriental Medicine, better known as NCCAOM. And many people just call it the national exam. This requirement is different from what we have now. At this time, you can be licensed in the state of Maryland either by graduating from an accredited school or by taking the national exam. And the purpose of this bill is to really bring Maryland on a par with 48 other states in the country which require the national exam. So this would provide the public with an objective evaluation of every practitioner's basic knowledge of acupuncture. It would demonstrate our board's concern for the safety of the public, and will also make reciprocity more available to all acupuncturists licensed in Maryland. The amendments that we're talking about are really not substantive. They are for purposes of clarification of the requirement. I'd be happy to answer any questions that might be had later about the purpose more extensively. But I thank you for your consideration, and I would respectfully request on behalf of the Acupuncture Board and the Department of Health that this bill be favorably reported.
Thank you, Ms. Black. I'd like to call Mark Levin, please.
Hi, thank you, Chairperson. So I'm Mark Levin. I'm president of Maryland University of Integrative Health. We are a private nonprofit health and wellness university in Howard County. We have a number of degrees, and one of them is acupuncture. And we are the only acupuncture school in the state of Maryland. And we very much support this bill. We think it's great that the requirement will be consistent with what exists in other states. And a key provision for us is the grandfather clause that was mentioned. And that's very important so that the existing students in the pipeline are not adversely affected, because we will need to make some curriculum changes. And that takes a process that we have to get MHEC approval and other approvals to make that happen. So that's why the grandfather clause to us is very important, so that existing students are not adversely impacted. But in the long run, we think this is a great change, and we're very much in favor of the bill. Thank you.
Thank you. That concludes the panel. Are there questions from the committee? I'll give you one more second. Any questions from the committee? All right, Ms. Black, Mr. Levine, you did a great job. That concludes the hearing on House Bill 188, and we will move to the next bill.
Thank you.
Thank you. House Bill 229, sponsored by Delegate Young, Pharmacist Administration of Maintenance Injectable Medications, Treatment of Sexually Transmitted Infections. Delegate Lewis Young.
Thank you, Madam Chair, and good afternoon, committee members. It is a privilege to be able to present to you 2 days in a row. This bill may sound somewhat familiar to those of you who were on the committee last year when we passed House Bill 135, which is Pharmacist Administration of Maintenance Injectable Medicines. That bill predominantly treated mental illness and addiction issues. Now, a bit of history. After we were fairly far into the process, the Senate added an amendment, and that amendment was to add STIs, or sexually transmitted infections. The House was pretty far along in the process at that point, and we did not accept that amendment. So I am back here after some data-driven determinations to ask you all to consider that this year. And when I say data-driven determinations, let me share my sources. There is actually a publication from the Maryland Department of Health, the Center for STI Prevention. They put out an annual report. It's a lengthy report. I'm going to give you some of the highlights. But let me just review why STIs are such a threat. They're serious infections that can lead to severe and lifelong health problems, including scarring and inflammation of the reproductive organs, which can result in pelvic inflammatory disease. It can also lead to potentially fatal ectopic pregnancies, infertility in women, and complications during pregnancy. In our state, now I'm referring to that report, over the past decade, we've had a significant increase. Chlamydia has increased by 38%, gonorrhea 50%. Just between 2012 and 2019, 99% increase in our state. Syphilis, 153%. Also, for congenital syphilis, we are the 9th highest in the country. What this is pregnant women who have contracted syphilis can transmit it, that infection, to her unborn baby during pregnancy. Another thing I learned from the report is these STIs disproportionately affect the minority population in our country. So this is a public health emergency, and it is another health equity issue, particularly about accessibility. So I want to also reference one other source, and that is the CDC, Center for Disease Control, came out with a report last summer. It's called the Sexually Transmitted Infections Treatment Guidelines 2021. And they actually recommended, because of limited accessibility, that pharmacists be able to treat with injectables STIs. So you might ask, why such an increase? And by the way, Maryland isn't alone. We're seeing these increases all over the country. There's probably 3 reasons as outlined in the report: substance use, poverty, stigma, unstable housing. They all limit access and prevention and care, decreased condom use among vulnerable groups, and finally, shrinking public health resources over years, resulting in clinic closures, reduced screening, staff lost, and reduced patient follow-up and linkage to care services. So since access is a serious issue, that's why I believe we should re-examine this issue and concur with the Senate in adding STIs to the list of injectables. Thank you very much for your time and attention.
Thank you, Delegate. Let's complete her panel, and we'll start with Belawo Awakoku.
Thank you, Madam Chair. And for the record, my name is Balawa Akwakoku. I am the State Government Affairs Manager at the National Community Pharmacists Association and CPA. We represent just about 20,000 independent community pharmacists across the country, including just under 400 in the state of Maryland. Those 400 pharmacies administered just about 22 million prescriptions in this past year. And I am here to ask for a favorable report on the bill. Over 90% of Americans live within 5 miles of a pharmacy, and that just underscores how much access, the accessibility that Delegate Young had emphasized, because that is many of the issues when it comes to health equity is access. Long-acting injectables have been used not only to just treat STIs, but also mental health disorders as well. If this bill does pass, that definitely will lead to better healthcare outcomes. The delegate has already stated the numerous issues when it comes to lack of access. It really just means that the health problems compound. So I hope that the committee issues a favorable report on this bill and that it is passed by the full Maryland General Assembly. Thank you.
Thank you. Matthew Hamill, please. Richard, is Mr. Hamill here?
Yes, ma'am. It shows that he is here.
Okay. Perhaps unmute, Mr. Hamill?
Okay. Are you able to hear me now?
We can't see you, but we can hear you.
Hold on one moment. I do apologize. I'm not used to looking at this kind of a screen.
There we go.
Okay, thank you so much. Thanks for your patience. Chair and Vice Chair, thank you for the opportunity to support House Bill 229. My name is Dr. Matthew Hamill, and I'm testifying in my role as a physician who has specialized in the prevention and treatment of sexually transmitted infections for more than 20 years. As you've heard very eloquently from Delegate Young, STIs are common. They're also hugely expensive. It was estimated in 2018 that the annual cost of STIs was in the region of $16 billion. And also in 2018, it was estimated that 1 in 5 Americans had an STI. Those most at risk of STIs, young people, people of color, and sexual and gender minorities face some of the most insurmountable barriers to accessing STI treatment. Between 2010 and 2019, rates of early infectious syphilis in Maryland increased by more than 250%. Public health efforts to date have done nothing to reverse this public health emergency. The CDC standard of care for STI treatment requires the administration of injectable antibiotics, And receiving such treatment from pharmacists is critical for a number of reasons. It is common practice. Most states already do this. It increases access for patients, and it addresses some of the inequities introduced by historic and current structures, such as lack of transportation. It expands patient choice, and it can decrease the stigma of coming to an STD clinic. Pharmacists know their patients, and they are very well trained in emergency management of adverse drug reactions. I would like to thank the committee again for the opportunity to testify, and I respectfully urge a favourable outcome on House Bill 229.
Thank you. Thank you much, Dr. Hamill. Aaliyah Horton.
Hi, everyone. It's nice to see you all. It's my first time testifying this session. My name is Aaliyah Horton. I am the Executive Director of the Maryland Pharmacists Association, and we are very much in support of House Bill 229. As many of you will recall, MPHA has advocated for broad authority for pharmacists to administer injectable medications. And this bill is in line with our overarching issue to provide that type of access. Over the years, it's been put together piecemeal, and this is precisely why we wanted that broad authority, so that we would not have to come back every single time to modify that scope of authority when there is a public health issue and a public need. So I did want to also reference the last 3 pages of my testimony. If you look at the map, the green areas are states where pharmacists have full authority to administer medications. And so what this bill requests is not progressive at all. We're kind of bringing up the rear. Thirdly, we did try to work with the Department of Health to get emergency authorization to provide this type of authorization at the earlier part in the pandemic, because of the need that was brought to MPHA's attention by the medical community. This was not a specific issue that was brought up by the pharmacy community, but the pharmacy community is here to meet that need. And you can see the list on page 7 through 9, again, of my testimony of all of the members of the medical community and public health community that are supportive of this effort. And lastly, I just wanted to mention that there is a question about whether this is considered a maintenance injectable medication. And during the Q&A, I'd be happy to talk about my thoughts on an amendment to provide some clarity in this area. And I've mentioned that to some of the other stakeholders who are interested in having that conversation, but I'm happy to elaborate when appropriate.
Thank you. And so I'd like to call Kyle Bukowski, please.
Good afternoon. Thank you, Madam Chair. My name is Dr. Kyle Bukowski. I'm a board certified obstetrician gynecologist and the Chief Medical Officer for Planned Parenthood of Maryland. As one of the largest providers of STI testing and treatment for the state of Maryland, we are in absolute support of HB 229. Most STI care and treatment happens in an asynchronous format. Patients come in for testing either due to symptoms or just for screening purposes, and then they leave our office and we get the result days later. Once we have a positive result, we have to call in a prescription, often to a pharmacy, for these patients to get treatment. Without access to injectable medication for certain types of STI infections, the option is either to come into a health center to receive that medication or to receive a lesser effective medication that is an oral medication. Same is true for expedited partner therapy for partners of people who test positive for STIs. The benefit of this, as everyone has alluded to, is that we increase access for people to get adequate and appropriate treatments in a timely and convenient manner for patients, which is really, really important. The other thing that hasn't been mentioned is there is an epidemic happening within this pandemic with relation to sexually transmitted infections. People are delaying screening, they're delaying care, but we know that they're still having sex. And we know that there is a hidden STI epidemic that is happening because people are not getting screened appropriately. And this will further improve the ability for us to respond to that public health concern. Thank you so much for allowing me to provide these comments. and I urge a favorable report on HB 229.
Thank you very much, Doctor. That concludes the panel. So I'll open it now to questions from the committee, and we'll begin with Delegate Kipke.
Aaliyah, would you like to expand upon your thoughts to amend the bill to address the concerns raised by the term maintenance?
So, as I mentioned, this started out as, I would say, probably 8 years ago, as an effort to have pharmacists be able to administer medications, that broad authority. The first step ended up being self-administered medication. Then we got to the long-acting injectables for chronic conditions, and now we're talking about STIs. And I hate to use this term, but I think that section has kind of been screwed up a little bit. It's messy. And so my suggestion is that we modify the statute to be on administration of medications, and then have the different categories so that it's clear and it's not a messy title. And so there can be a separate section on STIs, that or separate area that on the STIs that then references all of the education requirements, the notification requirements, all of the other piece that's under the long-acting injectable section, so that all the steps are still followed. The prescriber still has to determine whether the pharmacist gives the initial dose or not, but it just cleans it up and cleans up the section in the pharmacy scope.
Could be some work for the subcommittee. Delegate Krebs.
Along that line, if that definition is changed, which it sounds like it probably should be, will that eliminate the expansion of the mandated benefit, which would require the review and evaluation by the Maryland Healthcare Commission, if that is changed? Because that was one of the issues that that if it's under that category of maintenance injectable medication, then by that very nature, it would be considered a mandated benefit. So if that was removed, would that eliminate that review for mandated benefits?
I am not familiar on that part. I would have to get back to you on that.
Well, I suggest just read the League of Life Insurers.
I haven't seen
their
the full
letter,
testimony.
and it explains. And we have evidently under injectables, maintenance injectables, they're considered mandated benefits. And if we do that, then we have to have an evaluation of the cost of the state. But if it's removed from that, it would eliminate the need for that. So I'd like to make sure you cover both issues while you're looking into it.
I did speak with representative of the League of Life and Health Insurers, and I apologize if I got that wrong. He is open to having that conversation. We did discuss my idea, but we need to just talk about it more. And so I'm sure that will come up. I have not had a chance to read their full testimony.
Thank you.
And Delegate Johnson.
Thank you, Madam Chair. And Aaliyah answered part of my question about the written approval. I guess this is questions for Dr. Hamill. Doctor, it talks about the initial dose. How many STD injections are multiple injections?
Thank you for that question. So typically the treatment for late syphilis requires 3 injections of long-acting penicillin over a course of 21 days. The other treatments for sexually transmitted infections are typically a single intramuscular dose.
And these are already injectables that the pharmacy would have in stock?
I don't know the answer to that, I'm afraid. Others will be better qualified to answer.
All right, thank you. Thank you, Madam Chair.
Thank you, Delegate. Are there any other questions from the committee? Okay, seeing none, that concludes the hearing on House Bill 229 and brings us to the last bill of the day, which is House Bill 247, sponsored by Delegate Resnick. Insurance, Medicare Supplement Policy Plans, Open Enrollment Period Following Birthday. Delegate Resnick.
Thank you, Madam Chair. Thank you, members of HGO. It's a pleasure to be here before you today. I'm presenting HB 2247, which is what we refer to as the birthday rule colloquially. This bill is the exact same as introduced in the previous 3 sessions, and it accomplishes one simple goal. It allows seniors purchasing a Medicare supplemental or Medigap policy to have an open enrollment period, just like you and I do, for 30 days following their birthday. As a quick recap, though Medicare is a federal program and outside the purview of state regulation, Medicare supplemental plans are an insurance product that are like any other regulated insurance product by the state and administered by the Maryland Insurance Administration. Though advertised by insurance companies as having open enrollment, and seniors can choose the plan that best fits them, this is really only true upon initial selection of their plan. Once a plan has been locked in order to change later on, a senior must pass medical underwriting. This means that if an insurance carrier deems the senior to be too expensive because of a pre-existing condition or a major health event, they can deny them a change and force them to stay on a plan that is more expensive or has poor coverage that doesn't meet their needs. Now, how many of you know seniors on Medicare that get healthier as they age? By creating this roadblock to change, insurance companies are essentially forcing seniors into one plan and one insurer that they choose when they're 65 years old, or earlier if the coverage is because of a disability. 7 states, Massachusetts, New York, Connecticut, California, Oregon, Maine, and Missouri, all have some form of this already in place. 5 of those 7 states have a much more expansive policy. What I'm proposing, a 30-day window following a birthday, is in line with what California and Oregon does, and to me is infinitely fair. The insurance companies argue that it isn't fair to them if a senior is relatively healthy and on a cheaper plan until there's a major health event and then switches to a more expensive plan on a different insurance carrier. But after the Affordable Care Act, the prohibition of denial of coverage for pre-existing conditions makes this literally the case for everyone else, from subscribers to the Maryland Health Benefit Exchange to all of us who take part in the state employee health plan. If it's good enough for everyone else, why can't it be good enough for seniors on Medicare? 2 sessions ago, this committee requested that the Maryland Insurance Administration do a study of this proposal. And I provided that to you last year and again provided to you with testimony this year. Despite the protests from insurance companies last year, the overall conclusion was clear. The MIA found, and I quote, "The data available to the Office of the Chief Actuary does not demonstrate that the adoption of the birthday rule in Maryland would reduce competition and introduce competition and choice, or introduce any anti-selection or increased rates within the Medigap program. Data shows that the premiums in California and Oregon are largely comparable to Maryland. The experience of new and total experience do not demonstrate a spike. Enrollment does not appear to have been slowed down due to rising rates in California and Oregon, and competition does not appear to have been reduced." For the last 3 years, this has been an important issue to me, and I have brought constituent after constituent in front of this committee to advocate for this policy. This year, it became personal, as my mother-in-law was denied the ability to move coverage because she failed underwriting. Her major healthcare event, cataract surgery. If cataracts can keep a senior from accessing open enrollment, then why do we even pretend to have it? The data and the policy are clear. It is time for Maryland to adopt the birthday rule and give seniors a break on their Medicare coverage, Medicare supplemental coverage. Thank you for your time, and I urge a favorable report on HB 247.
Thank you, Delegate. I would like to call James Gutman, please.
Thank you, Delegate Colson, and good afternoon, members of the committee as well. I'm Jim Gutman. I'm a Howard County resident and member of the Executive Council and lead healthcare advocacy volunteer for AARP Maryland. Before my retirement for 25 years, I edited, published, and owned subscription regulatory newsletters about U.S. healthcare, including several Medicare-related ones. I'm here today representing AARP Maryland and its 850,000 members in support of HB 247, and thank Delegate Resnick for sponsoring this important bill. You've heard from Delegate Resnick about the general problems with the current structure. I'd like to give you a personal example, but before I say that, I just want to make clear that Medicare recipients now have only a 6-month window when they first become eligible for Part B to guarantee their selection in a Medigap plan. After that initial period, if they want to switch, as you've heard, it's really at the mercy of the plan. That was the case for my wife and me. We both had an extensive coverage Medigap plan for multiple years with Mutual of Omaha. But during the past 2 years, I have had premium hikes of 13.5% and 17.2% respectively, now leading to a current 3-month premium of $633. That's going to go up again when my renewal comes up in May, shortly after my birthday, even though I've had relatively few and minor claims during that period. My wife, who is 6 years younger than me, has had premium increases of 10.9% and another double-digit percentage before that. This bill would help in situations like this. It would give us a situation where we're not locked into a plan. It is in keeping with AARP's belief that Medigap should be affordable and available. And although we'd prefer full community rating and prohibiting insurers from varying Medigap premiums, this is the next best thing. And we urge your approval and favorable report. Thank you very much.
Thank you. Cornelia Bright Gordon, please.
I'm here, but the host has stopped my video. So if you could allow me to, thanks.
Got it. We can see you now.
Thank you very much for the opportunity to support House Bill 247. I work for Maryland Legal Aid, and I'm an attorney. I've been practicing law for 41 years, and I have a practice that centers, among other things, health law. This bill will require the Maryland Insurance Commissioner to permit a period of enrollment for individuals enrolled in Medicare supplemental policy plans to change coverage with an insurance carrier within 30 days after their birthday, even if their health conditions change. Medicare provides health care access to disabled persons and older adults. There are approximately 1 million people, 1.5 million people on Medicare in Maryland right now. I have submitted written testimony, and I urge you to take a peek at it if you would. There are about 84.3% of Maryland Medicare recipients are on original Medicare, and then they are subject to a 20% co-insurance. This co-insurance can produce a hefty bill. I've seen bills of $100,000. And for this reason, many people do purchase a supplemental coverage. Now, as indicated before, the supplemental coverage prevents catastrophic out-of-pocket billing for medical services. And very few people know about the 6-month window, sometimes until it's too late. The ordinary person who retires generally is not informed about it. They have to be kind of savvy, even when signing up for Medicare. People often learn about it when it's too late. Maryland Legal Aid supports House Bill 247 because it makes access to health care available to a vulnerable population, and it levels the field. We encourage you and urge you to issue a favorable report on House Bill 247. Thank you very much.
Thank you for your testimony. I would ask if there are any questions from the committee. Vice Chair Penny-Melnick. I think you're on mute, but now try. Nope, still can't hear you yet.
Can you hear me now?
Now we can hear you.
Yes, sorry. I was having trouble there with my program. So thank you for your testimony today. I was reading the MIA report and all the information that you provided for this bill. So there are a lot of New York, Connecticut, Massachusetts, and Maine. What have they done to address this issue? Because the states have now, a lot of states are trying to fix this because it's an issue. How does New York, Massachusetts, and Maine deal with it?
So, like I said, there are 5 states that do something more expansive than what I'm proposing here. And so I can give you the very quick, let me bring it up. Here we go. So in Massachusetts, New York, and Connecticut, they have what's called guaranteed issue, what Mr. Gutman mentioned, for year-round enrollment. That means that at any time a senior wants to switch plans, they can switch plans at any time in the year. It doesn't have to be around their birthday. Maine, you can switch one time within a 1 month period anytime during the year. So it's basically rolling. And Missouri has a 60-day window. California and Oregon have that 30-day window, which is what I'm proposing here. And that very much lines up with a typical open enrollment period on any other insurance product. When any of us who have employer-provided health insurance or are on the exchange, when we have the opportunity to switch, we usually have a period of about 30 days at the conclusion of the subscription period to be able to do so. So I wanted to make sure that it matched up.
Okay, thank you.
Any other questions from the committee? I have a question, Delegate. Would you be open to a delayed implementation date, say July 2023 or 24, in order to give the insurance carriers the time they need to adjust their technology, et cetera?
Yeah, I'm open to having discussions about, amendments to the bill in order to make it more feasible to implement. I don't know what the appropriate implementation date would be, but if that is a stumbling block, which frankly is the first I've heard of it this session, I'm open to having that discussion.
Thank you. Seeing no other questions, then that concludes the hearing on HB 247 and the work before us today. Thank you all very much.
I believe there's opposition testimony waiving emphatically.
Oh, wait. I'm sorry. Thank you for.
No problem.
How could I forget? There is opposition testimony from Matt Celentano. Sorry, Matt.
No problem. Thank you, Delegate Resnick. I appreciate that. Thank you, members of the HGO Committee. My name is Matt Celentano, here today on behalf of AHIP, America's Health Insurance Plans, in respectful opposition to House Bill 247. AHIP appreciates the bill intent, but believes that the bill will have unintended consequences of higher premiums for med sub purchasers in the state. Currently, Marylanders are generally eligible to purchase any Medicare supplement policy offered in the state during that initial 6-month open enrollment period at 65 or older when they first enroll in Medicare Part B. During the Medicare supplement open enrollment period, the enrollee has a guaranteed issue rights, like we heard before, cannot be turned down because of pre-existing conditions or health problems. It cannot be charged higher premiums based on health or required medical underwriting. If Maryland were to pass HB 247, allowing an annual open enrollment with guaranteed issue, the risk profile of the group will be altered. This will result in higher premiums in some products. Prior to the 2021 session, as the sponsor had alluded to, the MIA attempted to review the impact of similar provisions in other states. The MIA was able to look at the data from various sources, and the response is not inconsistent with the view of what will happen, of our view of what will happen under the bill. The MIA notes in their letter that they surmise the market impact to be a 2% net increase to the Medicare supplement market, meaning across the entire market. We don't dispute that assumption. We're focused on the varying experience of specific insureds, as the impact will not be an even 2% for all, but higher increases for some and lower increases for others, especially in the lower priced products. A close read of the MIA letter finds that on page 7, the MIA recognizes this reality, and they state the birthday rule is likely to drive up the lowest standard rates. Simply, we urge the committee to remember that the individual experience of insureds with different policies and carriers can vary. And because of this, we urge an unfavorable report. Thank you very much.
Well, thank you, Matt. And I apologize. I have now looked at the list very carefully. I see no one else on the list. Are there questions for Mr. Celentano? Vice Chair Pena-Melnick.
And thank you, Matt, for coming today and testifying. I have a question for you. I see the letter, and yes, it says that, but it also says that they don't believe it will have a huge impact. And they go on to describe other states that do it and are actually a lot more generous than the way this bill is drafted. So my question is, if it's been working in other states, it seems to be giving seniors, a break. And it's better for them to have insurance than not have any, right? So it's all how you see it. Is there any way that you can find or envision a middle ground to make this work? Would, just like the chairman asked the question about of the sponsor of having some type of language in there of a later implementation date, will you be open to having a review after 2 years or so to look at really what the impact is if there's some monitoring it? Because the problem that I have is that I see that other states, 8 already, are doing it. And you know what happens? It's going to keep growing because it is an issue for our seniors. Is there any way, any compromise language that you can offer?
Well, Delegate, thank you for the question, and I'm always open to a conversation. I will say that fundamentally, these products are different because it's not like these seniors had no coverage. These are supplemental products on top of the Medicare benefit that they already have. 2, we have seen some of the experience in other states, especially Oregon, which has a very similar law to what is being proposed here. And the rates have gone up to the extent that we just talked about, in the lower rates products more than others. And just to go back to the MIA rate, that letter, because I think it's important, on page 9, it says, quote, "We now see a lot of member adverse selection to the lower cost insurers on the market. After the insurer becomes the lowest rate in the market, or in the lower quarter of rates, the insurer sees sharp losses and can justify rate increases between 50 and 30% the following year." So it's not going to be uniform. And that's what we just want to make sure that you're all aware of before you move on this bill. Their probably net impact will be 2%, but can have dramatic impact in some products.
Thank you.
Thank you, Delegate. Madam Chair.
Thank you, Madam Chair. Matt, I'm trying to think about this as compared to other insurance products where people do have an open enrollment period every year.
Right.
And generally speaking, you insurers have managed to find ways to make this work, and it hasn't been a complaint that we've heard. Why is this kind of business different than that kind of business?
Thank you for the question, Chair Pendergrass. A lot of it has to do with the fact with the older risk profile of the population. And in the general commercial health insurance market, we're seeing a lower age band. When it gets to these types of products, the reason we have continued with guaranteed issue is to make sure that the risk pool isn't dramatically affected by folks that are getting sicker at an older age.
Follow up, Madam Chair?
No, thank you. Thank you, Madam Chair.
Thank you. And Delegate Kipke.
Thank you, Chairman. Matt, in any of the places that have these types of laws, are there have companies stopped offering products? Have they moved all, away from the, I guess, the higher benefit, higher cost plans? Have they stopped offering them, I guess is my point. What I'm wondering is, the worst case scenario, the worst fear is that people would game the system and they would only go after those more lucrative benefit plans if they have high health needs or large health needs. But I'm just curious, has anybody pulled out of the market as a result of that?
Delegate Kipke, I'm not sure if it's not my understanding that carriers have left the market. I think we're more concerned with premiums spiking, and the adverse selection will come along with folks hopping from product to product, like you mentioned.
Thank you.
Okay. Any other questions from the committee? Delegate Hill.
Yeah, I tried. I really did. But then Matt gave that answer. Matt, we're talking about 30 days out of 365 days. So from a realistic standpoint, how much hopping back and forth do you really anticipate there's going to be?
Well, Delegate Hill, it might be only 30 days, but at the age of 65 and beyond, people would develop health conditions at a much greater pace than you would in a younger folks that would be in the non-Medicare population. So the development of some of those health profiles that can be moved around from insurer to insurer have the potential to cost a lot more and to affect the risk pool. I'm not saying that this isn't a bad idea. I'm just saying that it's going to have impact to the market.
All right, thank you.
Delegate Sample Hughes.
Well, thank you, Madam Chair. And Matt, thank you for your comments here today for this bill. I guess my question is around the fact that you brought up the different products and benefits that the population would potentially get, and then therefore it could potentially increase the cost. In your research and looking at those 8 other states, has there been a trend on what particular product that they have jumped to and increased the rates that you have concern about?
Yeah, it's the lower price products that have smaller benefit that see the most dramatic increase. And as I think everybody knows, in insurance especially, it is all about the sticker price. So people don't necessarily pay as much attention to the benefit package, except for a certain population like all of us who are so in the weeds on this stuff every day. But most people are just looking at their bottom line. And ultimately, you guys have to balance the choice impact and how people find these products. And if it's an okay trade-off to have maybe higher premiums in the lowest end plans, that's a policy choice.
Okay, thank you.
Thank you, Delegate. Any other questions? Okay, seeing none. I don't think there are any more speakers for the day, which concludes our bill hearing. And thank you, Delegate Resnick, for reminding me about Mr. Celentano. That concludes the hearing on HB 247 and the work before us today. Thank you all for your time and your testimony. We will be having a voting session tomorrow at 1 o'clock. Thank you all and have a good evening.